Good afternoon, everyone. As Alicia said, I'm Andrea Verre, and my role is Director of Quality Management at Yale University School of Medicine, Department of Pathology. And when Sakura first talked to me about this presentation, Alicia and I came up with, you have made a decision to proceed with Lean and Six Sigma. You understand the process, and how do you begin and where do you start? So I'm going to try to explain to you what we did in those next 45 minutes and just see if I can jumpstart you guys into having some ideas as to how to make these methodologies work in your lab. As you can see from my first slide, I do have a background in laboratory. I have certification in cytology, specialist in cytology and molecular pathology, and also have done a lot of work in the last few years with surgical pathology and histology labs. So I think for me, that's one of the things that has helped, is that I do understand the lab environment, and I'm not a consultant. I am a laboratorian that has come, through the ranks and really want to make a difference in the lab. So my next slide says that I basically have just finished this year taking my black belt Six Sigma training. I've passed the test. I've done all the work, which was definitely a lot of work. And I just have to finish my project, which I'm in the process of working on now. I'm working on a project on frozen section processes and analysis. So quality management. The way that I'm going to tie all this together is, how does quality management and Six Sigma and Lean fit together? Most of the labs that's on this teleconference, I'm assuming you guys are all accredited or credentialed or certified by the organizations listed here: College of American Pathologists, Joint Commission, CMS. And anyone who has had to go through the regulatory process knows that the activities that they're constantly talking about is that we improve patient outcomes in healthcare, and the laboratory needs to be involved in that. And the key word here is that the laboratories and the organizations need to constantly improve patient outcomes. So why I think that Six Sigma and Lean is so important is that it really does provide a methodology for you to constantly be working on this. So the way that I started in my organization is I figured out that I needed a way to get people really excited, and how do we start? So some of these slides that I'm providing you are actually real slides that I used over a year ago, actually more like 2 years ago, when we started our process. Yale University as an institution was founded in 1701. The School of Medicine at Yale was founded in 1810. And the mission of the School of Medicine is to be a world-renowned center for biomedical research, education, and advanced healthcare. Our clinical service, so our histology laboratory and our gross room and our data entry and our pathologists, is mostly housed in Yale New Haven Hospital, which is a 944-bed tertiary care facility. Our annual pathology volumes, we do about 60,000 surgical pathology cases annually. We produce about 36,000 slides or 2,000 cases of immunohistochemistry annually. We do about 300 autopsies each year. We do about 100,000 GYN pap smears, 4,300 non-GYN cytology, and 3,300 cytology FNAs. Also in our program, we have about 60 clinical faculty. We're a very big organization. We have a lot of basic science research laboratories that are part of the Department of Pathology. Each year we have roughly 36 residents and fellows that come and go in our program. We take cytology students from Albany, and we also take pathologist assistant students from Quinnipiac. So what I'm trying to explain here is a little bit about our lab, how it could fit with your lab and how you're going to implement, and also just explain to you what I did in my lab to try to lay down what are we all about, what are we doing with this quality management and Lean and Six Sigma. So we also have additional specialty labs. We do cytology molecular testing quite a bit. We have several tumor-based molecular pathology laboratories. We process about 3,000 consult cases every year. So those are other surgical pathology laboratory slides that come here for our pathologists to consult on. We also have an electron microscopy laboratory. Also, what prompted some of our process improvement is that the hospital, Yale New Haven Hospital and Yale University combined, built a brand new cancer hospital, and some of you may have heard of it. It's Smilow Cancer Hospital in Yale New Haven Hospital. And the goal of this, the mission of it, was to consolidate all of the medical center's cancer services, both inpatient and outpatient, into a single world-class cancer hospital. It opened in October of 2009, so it's just barely been open 2 years. And just to give you a little bit of the facts about the building, it's 14 stories, almost 500,000 square feet, almost $500 million to build it. Another 168 beds, that's in addition to the 944 that we already have in the main campus. 12 brand new operating rooms that are mostly focused on, cancer surgeries, with a brand new frozen section laboratory. And if anyone wonders where the name came from, Joel Smilow was president and CEO of Playtex Products and also graduated from Yale, so he had donated the money, and that's where the name for the hospital came from. This is just a picture before the lab even opened. We were able to have all brand new equipment. This is our frozen section lab. This is just one side of it. The hospital and Yale spent a lot of money on brand new equipment and looking at really making a world-class cancer hospital. This is a picture of the sign-out area. We used to have a two-headed microscope with just a monitor that would display the microscope viewing, but now we actually have 3 of these 4-headed microscopes in this brand new laboratory to work on frozen. So one of the things that we really felt with this new cancer hospital is we really had to, as a laboratory, look at the future. We wanted to explain to our staff why we were going to start doing a lot of process improvement projects, why it was so important that we really had breakthrough improvements in our processes. We wanted to continue to build on the rich scientific tradition of the Cancer Center, and we also wanted to be able to support and expand clinical trials and programs that would build molecular profiling so that cancer treatments could occur with targeted therapies. So again, a lot of these slides that I'm showing you is how I kind of really worked with my staff and my managers and my faculty to explain why we were bringing in these methodologies, which is, I think, very key to success. So what I really did was I said, we really, even though we're a very good laboratory, we really need to change for this new change, 12 new operating rooms, and we needed to get all of our ducks in a row. So why do I start talking about Yale, and why am I talking about the age and the vision of this laboratory compared to Lean and Six Sigma? What I think is critical is that in the laboratory, you really have to remember your mission statements. You have to really remember your history. You need to look at where you came from, and you need to build those goals and values into your laboratory process improvement. And the other thing, too, is that if you really are going to have a well-developed program in process improvement using Six Sigma, Lean, or any other methodologies that are out there, you really need to be able to document and look back at your advances and document what your current activities are. And I think if you really follow Six Sigma and Lean, that's what you will automatically have happen. As employees at Yale University, we have many people counting on us to uphold the legacy and the passion for advancements that defines Yale School of Medicine. And as employees in this world-class institution, are we currently comfortable with our quality? And I really gave them time to think about that, like as far as what we're doing on a day-to-day basis. Can we get better? What is your answer on that? And I really worked with the staff about thinking, yes, we come in every day and we process many, many specimens, but can we get better? And universally, the answer was yes. Yes, we can always get better. I don't care how good we are. Process improvement is always there, and we always can get better. Okay. So how do we select Six Sigma? Why did we use both techniques? And one very critical question is, how do you break away from the day-to-day clinical operations in order to do this work? So one of the things that I feel is critical when you develop your program and you think about designing your program is you really have to think about quality. What is quality? One of the definitions of quality is the features and characteristics of a product or service that is able to satisfy stated needs. Someone has a stated need, and we need to provide that service. So another way to put it is customer satisfaction. And some of the basic principles of both Lean and Six Sigma is to really look at who are your customers. Six Sigma and Lean both are based on customer satisfaction. And basically what that means is you really have to look at all of your processes and who is providing you with a service and who are you providing a service to. And as Alicia and I were discussing before the conference started, a lot of these methodologies started in the auto industry, which we all know the customers of an auto industry are people who want to buy cars. But in healthcare or in the laboratory, we have customers too. In the laboratory, if you just take a quick minute and think about who are the customers in the laboratory, and I'm not going to advance the slide and just give you a quick minute to think about it. If you're in the laboratory position, whatever your function is within the lab, who are your customers? So one of the things that I like to say is in that gamut of customers, we may identify probably the most prominent customer that we all think about is patients. But we also have clinicians. We have pathologists if we're histotechs or accessioners or pathologist assistants working in the gross room. We have residents that are relying on us to provide a service to them. In my institution, we have a contract with Yale New Haven Hospital, so they pay us for our services, so they're a customer. Insurance companies are customers. So once you start to think about the customers that I've listed here, who do you think is harmed the most if we have poor quality? And so again, if you just take a minute and think, who is harmed the most by the quality if we have poor quality? And this picture basically shows a patient. This sweet old man, he's got his pen in his pocket, he's got his sneakers on, he's reviewing probably a laboratory test with his physician. So if we have poor quality in healthcare or in a pathology laboratory, I think it's pretty evident that this individual is probably harmed the most if we do make an error and we don't provide the service that this patient or this clinician needs. And what I try to do with my staff is just really try to bring it down to that grassroots start. If I'm going to bring in a methodology like Six Sigma and Lean and ask them to work on teams and use tools and use PowerPoint presentations to show what they've done, I want to really bring it back to the grassroots and say, here's this patient who could be harmed if we have poor quality. I also remind my staff that as healthcare workers in patient care, most of us came here because we enjoy being in the business of helping sick. We want to reduce patient suffering, and we do save lives in our laboratory diagnosis. I don't care whether you're the runner delivering specimens, the accessioner or the data entry clerk entering the specimen in, the pathologist assistant or the resident or the pathologist grossing in the specimen, the histotech preparing the slides, or the pathologist making the diagnosis, or the transcriptionist putting the report into the system and reporting it out. We all do save lives. But the most important thing is that our care does not always go as planned and errors do occur. Next, I personally, in my quest for quality management, have done a lot of work reading a lot of Dr. Berwick's literature. Dr. Berwick, I like to refer to him as the father of patient safety. He was the former president and CEO of the Institutes of Healthcare Improvement. He's a Harvard professor and a leading advocate for improving healthcare quality and efficiency. He currently is the new director under President Obama of CMS, so he will be working on healthcare process improvement. So I like to bring this person in because a lot of the literature or books that I use in my training and my work with my staff and managers are articles and things that Dr. Berwick has done. And one of the things that Dr. Berwick did, if you haven't read any of his book, in 2000 he was a collaborator and worked along with many, many other individuals on a book that was called To Err is Human. And in this book, one of the statistics that was written, which a lot of people in the healthcare industry had a lot of issues with, it said that the number of people dying in the U.S. because of medical error is equivalent to a jumbo jet crash on every single day of the year. So when I read this book, I said, can that possibly be correct? A jumbo jet every single year. And mind you, this isn't just errors in the laboratory. This is errors across all sectors of healthcare. You know, emergency rooms, operating rooms, nursing homes, laboratories, any of those healthcare organizations. And so I did the math. I took out my little calculator, and in Dr. Berwick, or in this book, I should say, To Err is Human, the statistics was provided that 98,000 deaths due to medical error every year. And so if you divide that number by 365 days, it comes out to 268 patients per day. And I went, wow, that is correct. And again, remember, all of the data in these books are based on research. And if you haven't read the book, you probably should. It's a very good place to start, or any of Dr. Berwick's other books. And what they said in this book is that that's more patients dying every day than breast cancer, motor vehicle accidents, and AIDS. So I really try to instill in the people that are going to be working on these projects with me that there's a moral imperative to act rapidly, decisively, and effectively. And how do we translate the will to act into action? Real improvements must come from the efforts of individuals within hospitals and healthcare organizations. And what do those individuals need? They need quality management. And as I said, we at Yale have backed up our quality management with looking at Six Sigma and Lean principles. We're still new at this. We have not been really doing this for that long. As I said, I personally have just finished my training, and I'm not completely certified yet. So we're still very young at this, but what we're trying really hard to do is to tie everything to quality management. We must develop training programs for patient safety officers within the organization. We must evaluate our systems, our processes, and our culture, again, key culture here, to reduce the occurrence of error. In reality, anyone that's a laboratorian, anyone that's involved in the laboratory process, you all are patient safety officers. I also try to work with people and understand that we do make mistakes, we do make errors, but would any of us want that one error to occur? No one would want their mother, their father, their child, or their spouse to be that one. So we really try to work with the staff and make them understand that every patient is an individual, and how do we avoid having one error on one patient. So when we then tie patient safety to anatomic pathology, what does that mean? In the operating room or in the hospital, it could mean a patient falling out of bed, or maybe in the operating room it means operating on the wrong site, which we all know that has happened in healthcare over the years. But in anatomic pathology, what does that really mean? A delay in a report sign out. If a report doesn't get signed out because the paperwork or for some reason it gets lost somewhere in the process, is that patient safety issue? In my mind, yes. A histology block loss, that could be the margin, or that could be the lymph node staging a cancer. A slide mislabeled. If we put the wrong slide label, which again, we're all humans and we do make mistakes, that is a patient safety error. Patient pap smear is misdiagnosed, frozen section evaluation when a margin is marked as clear and it really isn't, or my favorite, amended reports. When we amend reports, I have a fear that I want to make sure that that clinician and that patient actually get what they need. So what I really try to do is spend a lot of time before I bring in the Lean and Six Sigma principles, working this angle of making sure that everyone does have the culture of why we're here every day doing our job. And again, this is coming directly from Joint Commission, CAP, CMS, any of the organizations. The goal of quality management and patient safety is to reduce medical errors and improve patient safety through the design of a safer healthcare system. To err is human. We do make mistakes, and we need to learn how to deal with them. One of the things that I talk a lot about in my sessions is that a lot of times when people want to change processes and they want to really turn something around and they want to have a breakthrough improvement, there are people who stand in the way. There are people who, they've been working in the laboratory for a long time and they do certain things their way and they don't want to change. So I think what I really try to do is I really try to get everyone focused on patient safety and quality. If you're looking at a process because there's a problem with patient safety or quality of the process or errors, and we want to reduce errors, no one really can argue with you. No one can say, well, I don't care if that error occurs, because no one in healthcare is going to say that. We're here to do patients well and work on their specimens, and no one is going to argue with you if you really try all of your focus being on patient safety. So now I'm going to talk a little bit about the role of Six Sigma, Green Belt, and Black Belt, and really how you really have to bring it in order to be able to support process improvement. One of the things, the core principles of Six Sigma, is that things have to be projects, and you must have a team of staff members. Team members must be people that are directly involved in the process that is being evaluated. At the end of the presentation, I'm going to show you some of the data on one of the first projects that we did where we had some real breakthrough improvements, and we followed a very, very specific process. We had a project plan, we had objectives, we had all the pieces that a Six Sigma project tells you to do. And I'm going to hover on this slide for a minute because I want to say that whether you're the green belt or the black belt, whoever in your organization is going to be the leader of this movement, you are there to participate in the process and lead the process. You're not there to be the deciding factor. I cannot sit here and make a decision about how to cut slides in histology, or how to move specimens through the gross room, or how to make sure that slides in the residency and the pathologist signing out pathway are going to work best. You really have to build teams with the people that are involved in the process. Projects, projects, projects. In both Lean and Six Sigma, the methodologies really tell you that you need to define your project. And you really have to make sure that people understand that a project isn't just something to do. It's a means to solve a problem. You have a problem, you start a project. Or it's a means to design a new process or a service. How many of you have brought some sort of new process in, or a new instrument, or a new test in your laboratory, and we sit around the meeting room and discuss it, but we don't really sit down and document a quality improvement or a Six Sigma project plan. If you're really going to be truthful with Six Sigma and Lean, you have to do that. You have to have a project plan. The beauty of these two methodologies being in your lab is that if you provide that documentation, when CAP, when the Joint Commission, when CMS, or even your own internal quality assurance officers want to see what are you doing to improve healthcare, you already have the documentation. If you have a project plan and you work through some of these tools, I've provided a few tools to Alicia that show you what I've developed in my lab. When you do the documentation and somebody comes in and inspects you, you already have everything. It's all set up. Okay. Lean and Six Sigma both define quality as, quote, the freedom from troubles caused by office errors, processing errors, instrument failures, human errors, and defects. So on this slide, one of the things that I think is really important is that Lean and Six Sigma did not originate in healthcare. As we've already discussed, it started in the automotive industry, and a lot of other businesses and manufacturing companies have really adopted this. And if you look at that first sentence about the quality is freedom from troubles caused by office errors, processing errors, instrument failures, human errors, or defects, that can be applied to any business. It can be applied to an anatomic pathology laboratory. It can be applied to a clinical laboratory. It can be applied to an automaker. And one of the things I was able to attend, Dr. Zarbo does provide a session on process improvement at his laboratory at Henry Ford Hospital, and that was when I really kind of learned about the word defect. In healthcare, we don't really like to talk about defects, and quality assurance and risk management doesn't like to talk about it because there's always those risk management concepts tied to, oh, we have something defective. But it really is defective. When we make a slide wrong and we have to do it over, our QA or our QC process catches the error, but it really is a defect. And that defect alone slows the process. Going back to patient safety, a delay in a patient report. If we have to remake slides or reprocess blocks in histology, that is a defect. So we really try to move into Dr. Szarbo's world, which is talking about defects, and Six Sigma and Lean do the same thing. Basically, if you do have a well-functioning system under Lean or Six Sigma, there's two main components: the correct features, doing things right, and low errors. We know we're not perfect. We know we're going to have errors. The other thing is that many times when you read superficially about Six Sigma or Lean, people talk about breakthrough improvements and gains in profits or business plans that are very positively effective when labs or organizations do bring these methodologies in. And what Lean and Six Sigma, the basic principles are that when you do have the right features that the customers are looking for and you do have low errors, then those business profits will come with. All the labs and organizations are competing for work. We all know that there's a lot of changes going on in healthcare. We all are fighting, if you will. Fighting is probably not the right word, but we're all competing for the same piece of the pie. Every lab out there that I know of would like to carefully bring in more volume to their lab because that, again, sustains their viability and their organization. So the laboratory that can provide the most features with the least errors will maintain their own volume or increase their volume. And I'm sure a lot of you have read that there already are a lot of laboratories that have been very successful with this. Again, I'm getting back to projects. Lean and Six Sigma use a project-by-project approach. Both require a project charter, a project plan, data analysis, and a plan to control and improve the quality once the opportunities have been identified. Now I'm going to talk a little bit about this part right here. Again, I brought it up once, I can't say it again. How many times do people go into meetings and there's a problem? And we sit around the table and we talk about it, and people take copious notes, and everybody walks away and says, okay, we're going to meet in another 2 weeks or another month, and we're going to see what progress we have had. But the traditional way of labs is we're so busy every day making slides and getting the work out that sometimes we walk out of those meetings and we don't have any documentation, and the next time the meeting comes around, all of a sudden we've made very minimal changes in that. The positive way to look at projects is that it's a problem scheduled for solution. This is so key to Six Sigma and Lean integration, is that you really have to say that a project and a project plan and a project charter defining what you're going to do is a schedule. You have made a schedule to solve a problem. Okay, Lean, talking about Lean for a minute, Lean projects focus on eliminating waste and identifying bottlenecks. We all know in the laboratory that there are projects that do have bottlenecks. There are things that we have very labor-intensive processes in the laboratory, but we need to look at all those processes and that waste and see if we can identify them. Once we identify them, anything that's not value in the process, we have to systematically eliminate them all. And this, again, systematically, if you go into your project thinking that you're going to, in 1 week or 1 month or 3 months even, eliminate all of the waste or the bottlenecks in your process, you're going to be defeated from the get-go. You really have to systematically look at the process, look and use the tools that you all have learned with Lean and Six Sigma, and you really have to systematically integrate them into your laboratory. Do any of these things happen in your lab? Poor layout, equipment that breaks down, non-standardized work practices or methods. Today Susie's changing the stainer, tomorrow it's Bill. And do they change it the same way? Well, on certain days the stain's too dark, or on certain days the stain's too light. When you don't have standardized work practices and people do things you know, kind of a little bit differently, that can cause a problem. Workarounds. When certain people do processes and make too many errors, what happens is the lab has to work around it. And that's an identifiable waste. When you have to do extra steps just to fix something, that's a waste. For adherence to procedures, hopefully your lab has very good procedures, and if people aren't following them, then there are going to be quality errors. So it's really important that you look at your procedures and that you make sure with Six Sigma process improvement that those are adhered to. Ineffective scheduling of people, disorganization of clutter everywhere. I mean, I go out and do lab inspections for the CAP, and you know, there are some labs that are very well organized and there's some that aren't. There are times when our labs are really clean and tidy, and then there are other times when they're not. But if you really follow the principles and the tools that Six Sigma and LEAD provide you, you can get away from that disorganization. Data. Data is always so critical with these projects because people want to see improvement and want to see that it's demonstrated. So really, if you don't have good data about what your processes are like, you need to get to it, and that's, again, the tools of Six Sigma. This is not the greatest slide, but it's basically the iceberg, and we all know about the iceberg. The iceberg is the epitome of problems. Once you start seeing the big problems that are visible and you start eliminating them, then you're going to start to be able to work on all of the hidden things and the things that you don't even know are going on in your lab. And like I said, in our laboratory, we've found that out. We found that there have been things that until we really start looking really closely, we don't know what some of the hidden things are that are going on. Variation. When I went to my Six Sigma Lean training, this is the focus. Variation in a process is what provides some of the problems for our customers. A lot of times our clinicians or our clients will say, you know, if I know I'm going to get the biopsy report in 48 hours, then I can talk to the patient. I can make sure the patient calls me. But if it's going to be 72 or longer, just tell me, and then I don't have to worry. So those variations that occur really do cause problems in the process. And what Six Sigma does is try to stabilize your process and have constants in your process. Predictable, reliable, and expected. This way clinicians can plan their treatments, pathologists can plan their day if they know exactly within a range when their slides are going to be ready, when their special stains are going to be ready. So the goal of the Six Sigma is reducing variation. A Six Sigma process. So I'm assuming that everyone in the audience, or most people in the audience, are pretty well versed with at least what Six Sigma means. Well, what the whole concept of Six Sigma is that they're processes that are designed so that a process runs within 6 standard deviations away from the mean of the process. And the process is stable and only produces 3.4 or fewer defects per million opportunities. One of the things that people that start working with Six Sigma don't understand is that standard deviation is normal. There is always a distribution in how we do things. We will never be cookie cutter. We will never be exactly perfect. There are variation in events that happen in the lab. There are variation in specimens. There are variation in lots of stains. There are variations in people. And there are variations in life. So this last part of the slide, which talks about if you're going to base your process improvements on a Six Sigma methodology, you really have to understand what standard deviation means, and that standard deviation is normal. And the goal of this is to have as little deviation, as little variation. If you have never done a Six Sigma calculation and you want to start learning about Six Sigma, it's very enlightening to just look at anything in your laboratory and really come up with a Six Sigma calculation. Where is our process? How many deviations or how many defects do we have in our process? So if you haven't done that, do it. I'm assuming that a lot of the people in the audience are going to be responsible for bringing these methodologies in and being the champion of these methodologies. And so if you haven't had the opportunity to do this, do it. Then you really need to look at value. And again, we're going to talk about customer service because they're core principles of these two methodologies. Value is an action that transforms or shapes an item or material, such as a block or a slide. Value will help you being able to identify the waste. And this may sound silly, but sometimes with a process map or with looking at a process in your laboratory, you have to pretend you're the block. You have to pretend you're the specimen. You have to pretend you're the slide. You have to pretend you're the paperwork. Sometimes you cannot see things until you really really closely follow the process. So we actually, when we first started with our first project, we had process maps where, okay, I'm a block, and where do I go? Because it's so easy to say, okay, well, a block comes in and the grocer creates the block, and then histology puts it on the tissue processor, and then the histotech cuts it and makes the slide. But think about that. Just think about your own lab process. Think about how many processes in there go unnoticed. Waste. Again, these are all things that you're going to see in your Six Sigma or Lean principles. And overproduction, waiting for slides, transporting slides, poor process design, excess inventory. We already talked about defects and staffing. Data. All Six Sigma and Lean projects are supported and educated by data analysis. Whoever's going to lead your project has to be good or above average with computer skills, and if you're not, find someone. We all have people that we know love computers. So you don't have to be the expert. You can lead the team, but you do have to have a data and a computer expert. Okay, so now I'm just going to talk about my top 10 in my last few minutes about what are the keys, and then I'm going to quickly show you our last project. Again, number one, tie your Six Sigma and Lean to patient care and patient safety. No one can argue with you. Number two, I feel strongly that someone has to be trained in these methodologies, and I don't mean a 45-minute Sakura teleconference, which we're very happy that they provide, but somebody really has to get into it. Somebody has to be trained. Just a quick mention that from my experience, to get a green belt, and again, I did go on to the black belt, but just to get a green belt, which I think is enough to get you started, it costs about $5,000 and roughly 4 weeks of work. It's not continuous. Some of it is in class, some of it is self-study, some of it is projects. But for about $5,000, you can get somebody trained. Just think about for a minute if you send people to a scientific conference or, across the country between airfare and conference fees. Think about how much you spend next time on somebody going to an annual scientific meeting. Okay. Number four, you have to have a team. One green belt can lead and train several members, but you really have to have a team. No one can do it alone. If you don't have a team of people working on this together, you won't have any momentum and you're not going to hold each other accountable. Number five, get books, guides, and really learn material. You cannot do this in a 1 or 3 hour session, as I already mentioned. Number six, understand the basis of statistics. A lot of lab practices are based on statistics, so we may have to go back and relearn some statistics, but you really have to. You really have to understand the basics of statistics. And again, you may just need to find somebody in your group that does. Create a presence. The 2 items that I gave to Alicia to provide were tools that I made for my department, and I put Andrea Verre, Quality Management, Yale, Pathology. Do the same thing. Make a presence. Create your own tools. Number 8, play the political game. People like to say they don't play politics, but sometimes you do. If you don't have people in your boat, if you don't have people on your side that really want to change, that want to play in the sandbox with you, it's not going to work. You really cannot. You have to have individual conversations with people and understand what the problems are. Do the math, show me the money. In my department, this change that I'm going to show you, the way that we got the money for it was we tied this to patient safety. We were able to get some funds freed up for the project that I'm going to show you because we tied it to patient safety. Show them the money, show them how it can make an improvement. Data, data, data. Everything we do can be assessed in some way. Sometimes people think in the laboratory, because we're not churning out like a lab, like clinical chemistry, we don't churn out all these numbers. But in anatomic pathology, we do. Everything we do can be measured. You just have to be creative, and you really just have to use the tools to design data collection. Okay. So what we did in our department was we had a project that was called Yale Pathology Barcode Project. It was a great way for us to start. It was something that we had always wanted to tackle. Barcoding was out there. We weren't sure which way to go. We knew we had data that we had a problem, and we used data to support this project. We involved our staff, our pathologists, our lab aides, our managers, our administrators, and our chairman. We made sure when this project started that we had the buy-in of all of these people, and we had regular meetings where all of these people were invited. They didn't always attend, but it was their choice to not attend, or it was their choice to attend. Again, making that commitment. So what we did was in September of 2008, we had a process improvement project that was supported by both Lean and Six Sigma. And the purpose, again, project charter definition, we wanted to make specific changes in the flows from grossing to histology and on into the spine out area for surgical pathology in order to improve the quality of all aspects of the patient care process. We tied our objective and our purpose back to patient care. These were the objectives of our process. Again, more clearly defined, that the project had to be clearly defined, what we were planning to do, and what the benefits would be at the completion. Okay, so our objectives were to reduce complexity in our process, to give consistent delivery of slides to our pathologists, to have significant improvement in productivity. We wanted to make sure that we were producing slides the quickest way that we could. We were bogged down with paper logs with our old system, and we didn't really have a good verification for each individual block and slide. So we really had to have a verification process that was accurate. Part of this process, too, was that we only had one stainer. Yes, I admit it. We only had one stainer. So when our stainer was down, that affected patient care. That affected patient safety. And we really wanted to build quality in the process. So what we did was we took on a very large project where we did tons of process mapping, tons of evaluation, talking to staff members, histotext pathologists. And I don't know how this came up in your slide. Hopefully it's not too dark. What we did was we designed our own histology asset tracking and basically built a barcoding system. But what is key here is that we used all of the tools in Lean and Six Sigma to do this. So this project, like I said, we started it in September of 2008. We started collecting our data. The left-hand side of this graph is November of 2008. And all of these colored items are defects that happened in our process. So what I can tell you is that November of 2008, which is on the left-hand side, was when we started. In August of 2009, which is about halfway through, was when we really started to put the barcoding and the truly newly designed process in place. You can see how in a matter of about 3 to 4 months, how much our errors dropped. And again, the arrow at the top is the, quote, histology asset tracking and how these errors, and these were things about wrong stain, technical poor quality, entry into the computer. Okay, and this is just another representation of it, how it really, you can see how through August of 2010 it really did decrease. So what does that mean to pathology, and how do you jump in and start the cause? Always investigate quality in investigations when errors occur, document errors, shift from reactive to proactive, make improving a way of life, not a thing to do, not something that you do. It's what you live and breathe every day. Examine the quality in your lab and make a difference. Again, my almost last slide. Keep your efforts focused on patient safety and quality. Tie all those Six Sigma tools and Lean tools. Get the books, learn it, tie it to patient safety, and no one can argue with you. So again, at Yale, we were really successful with this first project that we did. And again, it involved a lot of different people, but we were very successful, and we supported all of this with these tools. And we only expect it to get better now that, personally myself, have had formal training to the level of a black belt. So with that, Here's my email. I welcome anyone that wants to email me if you want to share more tools. I have provided Alicia with a couple tools, and I thank you for your attention and turn the teleconference back over to Alicia.
Thank you, Andrea. That was a great presentation. You provided a lot of information as to what people should actually stop and think about before they jump into one of these processes. I appreciate that, and I'm sure our audience does as well. For our audience, if you have any questions, please type them into the question box now, and I'll give you a couple of minutes to do so. So as always, we have a featured product. This month's featured product is our TissueTech Auto TEC. It allows for continuous loading, labor savings, the ability to produce same-day results. We have reduced liability with the introduction of our Paraform cassette. So once the cassette is closed, it's never opened again throughout the processing and embedding steps. It does streamline your workflow, and it provides walk-away convenience. Additional information for the Auto TEC can be found on our website at sakuraus.com, and you can go into the products page and find information there. We also wanted to inform you about our upcoming webinar, and that will be the last webinar for the year. It's scheduled for November 17th. Standard time, 10 a.m. Pacific time, 1 p.m. Eastern time. And Bill DeSalvo from Sonora Quest will be wrapping up the webinar series for us. And the presentation will be Managing the Revolution and Moving to Innovation. If you haven't already done so, please register at sakuraus.com. And I want to thank you for your time today. Once again, CEU credits will be issued next week or the following week via email. And at this time, I would like to open it up to questions. I have one. You ready, Andrea?
Yes.
Okay. It says, did your error data come from your LIS system pre and post implementation?
The error reduction data was, in the beginning, was a combination of manual collection and LIS. Once we did put in the barcoding, and along with the barcoding, we really did change our process quite a bit, which again was why we needed the Six Sigma tools to totally look at the process. But from there forward, most of the data collection is coming from the LIS system. So we are able to capture through our barcoding, because the asset tracking is actually to the level of block and slide. So every single block and slide now is an asset. So we have data on every single block, every single case, every single block, every single special stain. We've just moved it into immuno and moving it slowly into the molecular diagnostics area. But basically, any process, we do capture the data now. So going forward, it's completely through the LIS.
Thank you. And the next question is, what barcoding system did Yale implement?
We built our own. We looked at a lot of systems, and we have very talented IT here and people that are very involved. So our own department, IT, wrote and worked along with our histotechs. We had meetings where the histotechs sat and looked at the development of the software. It does integrate with COPATH. We are a COPATH user, so some of the data is extracted out of COPATH, but the histology barcoding software is our own product.
Great, thank you so much. The next question is, what method do you recommend a lab to use to collect defect data? We have a QA log, but people have been reluctant to use it.
The thing that's key with any process is, I'll be honest with you, I really still think that in the laboratory, manual logs are good, because people it needs to be easy and it needs to be accessible. The key is that then you somehow have to put that data into a computer. We use Excel a lot. We use Excel to just summarize data. If you do go to a training in Six Sigma or Lean, there's a software application called Minitab that is really easy to use, and it displays data wonderfully. I just learned this software. It's again, it's Minitab. I mean, we do occasionally use FileMaker Pro because we might want to sort through data records. But again, the comment about people being reluctant, if people are reluctant about using it because they don't want to point out errors that somebody sitting next to them might see, what we have done is we do have anonymous emailing. We have a path quality email, so if somebody sees an error that they want to get to me as the quality manager, they can send me an email. Nobody sees it. We also have the same thing for our safety committee. It's an email process where it's confidential. So I kind of think that's where the comment's coming from, is that, you know, like I said, we still do find that people don't want to talk about errors or don't want to point out errors because they're afraid of, you know, their coworker being offended. So the answer is basically, I still think you need to start with paper. You just need to be meticulous with it, and you do have to put it into some data collection system, whether it's Excel, Minitab, Access, FileMaker Pro, whatever software you want to use.
Thank you. The next question is, did you get support from your lab or hospital to obtain the Six Sigma training, and how did you present your idea for training classes?
Yes, I will admit that Yale New Haven Hospital is its own corporation, and Yale University obviously is its own corporation. So my position as Director of Quality Management is kind of a joint venture between the two organizations. So basically my salary is split between the two. And so I was able to have the funding through my department to get the funding to go to the Six Sigma. I will admit, with my laboratory background, I usually go to a lot of meetings every year, scientific meetings. I did not go to any this year. I didn't go, well, I shouldn't say I didn't go to any. I didn't go to the big expensive ones that I normally go to. So I was willing to sacrifice a scientific meeting for this training. And the way that I presented it was, what I did was, we have a core group of clinical managers, and I got their buy-in that we were going to train our people. It was, you know, obviously a lot of the training hasn't been as easy with our residents and faculty because, you know, they are working on a day-to-day basis on a lot of different things, but in the labs, you know, we already have time set aside for process improvement or lab meetings or whatnot. So I was pretty successful with getting managers and staff to want to work with me. But again, some of these slides that I put in this presentations are the ones I used. I said, you know, think about the patient. So I hope I answered all those questions.
Thank you. Have a few more. Can you, okay, where can we obtain Six Sigma guides to do the same standard deviation calculation? Is this something that is only available through Green Belt training?
No, to be honest with you, if you go to Amazon or Barnes & Noble, and I'll be honest with you, that's how I started, you can get a book. You need to look for some sort of, I mean, these types of principles are being taught in colleges and universities. There are textbooks out there. There are textbooks on project management. There are textbooks now on process improvement. Because I have purchased from Amazon healthcare quality textbooks, I constantly get emails from Amazon, you know, you bought this book, you may like this book. It's really very simple to calculate the defects. And again, my email is available. If anybody wants to email me, I'd be happy to share some of the simple calculations. It's really simple to break down and come up with, hey, where do we stand in Six Sigma? What is our process? So, I mean, again, not that I'm a huge proponent of you know, identifying specific books, but just start looking, and you have to, somebody has to be committed to the process. Somebody has to find that textbook. Somebody has to read and water down, if you will, distill down to how do we really understand the principles basically, how do I do a Six Sigma. And again, my email is available. If anyone wants to email me, I can share more specifics. I can say that I did go to the Juran training, Duran Institute is in Connecticut, so I was fortunate that I have a family. I didn't want to really have to go far away, and I was very fortunate that the Duran program is in Southbury. It was a very good program. My institution supported because we have done other things with Duran. Duran has a website with a lot of material. So again, that is the program that I went through.
Okay, and I think we have time for one final question, and it is, did you perform value stream analysis as well, or was this purely a Six Sigma project?
I'll be honest with you that we started with Six Sigma and started to bring the lean in afterwards, because I'll be honest with you, the processes were so, I don't want to say antiquated, but we were doing a lot on paper. Our histotechs had to literally look at logs 2 or 3 times in their whole process, paper logs. And we process about 200 specimens a day, about 2,000 blocks, and probably about 15 to 1,700 slides every day. So if you can imagine paper logs, that's really a problem. So I really think that that's where you have to start. You really have to start with the Six Sigma, and then the lean kind of comes in. And again, I will say that the lean for us was afterwards, when we kind of really looked at the process and then went back and further nitpicked and said, okay, well, we don't need to do that with that block. That block really only has to go 2 steps. It doesn't need to go 4 steps.
Well, thank you. I appreciate your time. And if I can just get one more question in there, I know we have about a minute left. And it's the final question for today is, can you elaborate on your root cause analysis, and it's in parentheses, vital X's, that moved you to the selection of barcoding as the solution?
The vital X's. I really like that root cause tool, if that's what you're referring to. Most people that have done any work in process improvement know the 5 whys. When you have a problem, you keep asking why to really get to the root cause and the vital X's. For us, like I said, the vital X was that the pure volume of blocks that we handle every day and the complexity of what we do. Again, we have a huge residency program here, so our residents rotate through the gross room. We have PAs, but we also have residents that go on service for a month on a time. They're on breast, then they're on GYN. So we have such a complex process that month that the residents were on service, it was like we almost couldn't have a process on paper or a physical process that worked without us losing things and misplacing things or spending a lot of time looking for things. So the vital X's for us were accountability of the blocks and verification of where everything was, and that we could no longer do that with paper. We had to get away from paper. So the vital X's to us were clearly, accountability of every single block, every single slide, and the vital X's were accepting the complexity of our system. We could sit here and say again and again and again, well, we need the residents or we need the PAs to do this. The solution here is that complexity and that turnover of residents that are learning is part of our process. So the vital X for us was we have to learn how to work within our process. And we knew that looking at redesigning the process and overlaying barcoding so that each asset in our department was accounted for and could be quickly identified when we misplaced it or didn't know where it was, those were the root causes of the problem.
Well, thank you so much. I do appreciate your time. And if I get any other questions, I will go ahead and forward those to you. And thank you again for your time.
All right, thank you too.
Thank you. Have a great afternoon.
You too. Bye.
Bye-bye.